record. Hi everyone, I'm AM and I am the lead of live sessions. Today we're here with Dr. Anani. We're going to go ahead and start off with our startup PHS presentation. Oops, that is not the one. There we go. And share. Awesome. So thank you for joining us today. We are Pre-Health Shadowing. We are an international student-led, woman-led, minority-led nonprofit for medical advancements. We have closed captionings during our sessions to accommodate students of all abilities and needs. If you need any help to access it or any possible advice on how to make our organization more accessible, please go ahead and email us at info@prehealthshadowing.com. And you can save us as a contact to keep us out of your spam. And you can also join our email list to never miss an upcoming shadowing session. And if you want to stay in the loop, you can go ahead and follow our social medias. Our Instagram and TikTok is at Pre-Health Shadowing. We host students from all over the world. So where are you calling them from now? And you can put that in the chat. I am from California. So it's super cool to see where everyone is from. And if you're interested in being a part of our family on Pre-Health Shadowing, we are always accepting student volunteers, and you can go to that by visiting www.prehealthshadowing.com/medical-shadowing/volunteer. I'll be putting these links in the chat as well. And we're currently looking for team members, so you would go to www.prehealthshadowing.com/contact/join our team. And our leadership roles within PHS are very diverse. We currently have roles in IT, grants, fundraising, and so much more. You would just have to go to our website. This is what the application will look like. And if you're a high school student, you can go ahead and join our high school training program, which is called HTP, and it offers similar things to other leadership roles within our organization. And that's also found on Join Our Team. And if you're looking to make your resume pop, you can go ahead and submit your articles, reflections, reviews, and success stories to our website. And that is called www.prehealthshadowing.com/blog submissions. Because we are a nonprofit, we solely rely on our amazing volunteers' time as well as the donations of our volunteers and people who watch us. So if you can, please donate. This is a QR code. You can go ahead and scan it. I'll also be showing it at the end of our presentation. If you have any questions, you can go ahead and put it in the chat. Our co-host, which is I right now, will go ahead and say them out loud during the Q&A session, which is towards the end. Make sure to take good notes because you do have a post-shadowing assessment, which is available to earn your very own digital certificate verifying your hours on our professionals courses. And we do ask that you put on your cameras because it really helps with the online experience of shadowing. But yeah, I will go ahead and stop sharing so that Dr. Anani can go ahead and start.
That sounds good. Thank you, Am. I truly appreciate it. I am loading up the presentation now. I love seeing all the cities where everyone's from, so that's like really awesome. So we're kind of all over the country right now, so that's pretty good. A lot of California here, there's nothing wrong with that. That's ironically where I was born. I just don't live there anymore. So my name is Dr. Anani. Yes, Love. I am one of the mentors for Tour for Diversity in Medicine. I am their assistant director for social media, but I also am one of the mentors to go out and give talks such as this. Today's talk is about 45 slides long, but if you have questions, please put them in the chat. Here at T4D, as we go by our acronym, we're very interactive. So if you have a good question, I don't mind stopping. I don't mind asking or answering anything as long as it's relevant. If I feel like it's better for the end, I will just mention that. So drop them in the chat and that'll be great. And there is some kind of interactive sessions here. So feel free again to use the chat and kind of drop your answers in there. There's nothing too crazy or too big. It's the emergency department. We're very chill, except when things get crazy. So let's get started. Shadowing the ED, a shift of color, that's the title. What we will be looking for in our agenda here, we're gonna give a little bit of background about me. Then we're gonna talk about the road to emergency medicine, how you get here. 3 real cases. All 3 of these cases happened to me in the last month. So that'll be pretty amazing for you guys to hear. You'll hear my personal thoughts, kind of as if we were on shift. And then again, Q&A. Then we'll drop some T4D contacts and go from there. Hopefully everyone enjoys it. The way I frame this is we'll be pretending as if we are on a shift, right? As we're sitting down in the area and nurses come and give us things at different times. So be ready for that. But first, a little bit about me, so you know I'm not crazy. I work for American Physician Partners. I am a medical director, which means I'm over their site and I kind of hire the doctors, fire the doctors, make sure they see patients, handle patient complaints and things like that. The hospital I am at is TriStar Northcrest Medical Center. It is in the Nashville, Tennessee area. It's about 35 minutes north of Nashville, technically. It's in Robertson County. It's a small community hospital, but I love it. Been there since 2015. I am also the Robertson County EMS medical director. So all the ambulances, the drugs they have on it, to dispense drugs in the country, you have to have a physician sign off on it. So basically I work and come up with all the protocols with the department, and then anything they give is a protocol under my name. And then I help sign off to buy all the drugs on the truck and everything else like that. The good drugs, not the bad ones. I am board certified in emergency medicine, so that's all I do. I don't do anything else, and I love it. I enjoy video games a lot. I have a PS5. That is my most current system. Destiny 2 is my game of choice at the moment, but I have Horizon and several others. You can save that for the Q&A session if you'd like. I did marry my high school sweetheart. Her name is Lucetta. She is a neonatologist at Vanderbilt. And she is way smarter and more important than me over there. So if she ever gives a talk here, I'll let her do her own little intro. And my 2 bosses at home are Joseph and Jacob, AKA Iron Man and Hulk. They run everything. And the reason we set this time up is because their bedtime's at 7:30. So I have a little monitor over there. So if they cry and I get up and run, I apologize in advance. All right. So on to the case, or on to the road to emergency medicine, sorry. So as everyone knows, you have to do undergraduate time 2 to 4 years. Notice I did not say get an undergraduate degree. It is actually a false thought that you have to graduate undergrad to make it into medical school. You just have to finish the prerequisites. My wife did a BSMD where she just did the prerequisites in 2 years, got into med school, and then actually her first 2 years of med school counted as the last 2 years of her undergrad, and then they gave her a bachelor's degree. Other people just go straight in and don't care about the bachelor's degree and say just give me the MD. You have to do 4 years of med school. I put the little squiggly sign because hopefully it takes 4 years. Some people it's 5 or 6 years, but they're usually 4 years, and I hope that you get done in that time frame. You apply for the match, which is like the draft if you watch sports for medicine during your 4th year, and that is when everyone finds out what specialty they're going into. If you match into emergency medicine, those residencies are 3 to 4 years. Some programs are 3, like the one I went to, and some are 4 because they have like a research / like elective year that all of their residents get to do. And then after you finish residency, you're an attending forever, like me. So you have to keep your board certification up every 10 years, but after that, you practice on your own. All right, any questions about that before we move on? All right. We're going to go into case 1. And if you're still typing your question, don't worry, I'll go back. Case 1, the patient's name is Pop Pop. Again, was Ian my first choice for Matthew? Yes, it was. I watched a lot of TV growing up, especially shows like ER, and I thought that's what doctors did. I thought they just sat in a building and waited for people to come to them. And I learned that's not what happens in all the other specialties. So that's what does happen in EM. So I loved it. I don't like knowing what's coming in. I like sitting there. If you need me, I'm there. And if you don't, I get to do other things like answer emails or watch TV. So I love my specialty. All right. So Pop Pop is in. He's an 83-year-old male who's self-identified. He comes in with chest pain. His HPI is told by his daughter, and HPI stands for history of present illness. Pop Pop woke up. His daughter said suddenly about 12:30 a.m., and she said his chest was hurting. Pop Pop told his daughter it was severe and crushing. Pop Pop has never had pain like this before, and now he's sweating. So I want everyone to think about that while I look at the next question. I chose EM, Carolyn, because that's how I liked it. The only thing that made me second guess my choice was how hard of a specialty it was. And so kids are cute. So I really did think about pediatrics for a while. They almost drew me away, but then I realized I can see kids in the ER. So I stuck with emergency medicine. All right. So everyone knows that Pop Pop's having chest pain. He's sweating. So we're going to go and see him and ask our own questions now. So this is what we call a review of systems, right? So you get to ask your patient your question, and they're supposed to respond back to you with a yes, no answer or how they're feeling. So I will give everybody 30 seconds to type in the chat what questions they would like to ask Pop Pop, and I will answer them for you as if I was him. It's no question too big or too small. Yes, I have a stopwatch. No, there is no family history of chest pain according to his daughter. No, nothing makes the pain better. Moving makes it worse. If he gets to walking, it hurts. They had to wheel him in. He's never had any chest pain like this before, Nadia. Never, ever. Pop Pop was asleep. Pain woke him up. He does not have shortness of breath. It's just hurting. Good question, Jackie. Prior to going to sleep, he had dinner and he watched the news 2020. He has not broken anything. He doesn't believe he's fallen down. He had no prior procedures. He's on hypertensive medication. He ate meatloaf and mashed potatoes. His only current condition is deaf and he wears hearing aids. He's on medication for hypertension. Does the pain feel contracting? No, it feels heavy, like someone's just sitting on his chest. He takes hypertension because his doctor told him his blood pressure was high, so he takes lisinopril every day, just like his doctor tells him to. He has no known allergies. Y'all are great with these questions. Love it. Lifestyle is he's an old retired man that lives with his daughter. He's had blood pressure for the last 30 years. He is not diabetic. No falls that he's aware of recently or that he can remember. All right. I'm gonna give y'all 15 seconds. Y'all ask excellent questions. Yes, he took his medication. Pop Pop never misses his medication because his daughter gives it to him. No major lifestyle changes, just living in Robertson County, enjoying his life. All right. Those are excellent questions. We're gonna move on and go to our physical exam now. This will be the last one for Victoria. Could his way of eating have any impact? No. He can eat perfectly fine. He can still drink. So we walk in the room and see Pop Pop. He's an elderly appearing male, well-nourished. So he eats appropriately, not overweight, just well-nourished. He's visibly uncomfortable. And there's this buzzing in the room that you can just hear. It will not go away. When asked what the buzzing was, his daughter says, oh, those are his hearing aids. She took them out. He has moist mucous membranes. ENT stands for ear, nose, and throat. So nothing is abnormal there. Cardiac, he has normal heart rate. So it's beating between 60 and 100. And it's a normal rhythm. And there's normal sound. So I don't hear any abnormal murmurs or anything like that. We hear good breath sounds from Pop Pop on both sides of his lungs. His abdomen is soft, non-tender. You can press on it. His extremities have no deformities, meaning they're just, normal arms and legs. Normal color for his race, but he is sweaty. Like you can see sweat is on his face and he's just leaning forward like he's kind of huffing and puffing a little. These are Pop Pop's vital signs. So his blood pressure is 180 over 109. The top number is systolic, bottom number is diastolic. His heart rate's about 68, again, normal. He's breathing about 16 times a minute. His oxygen saturation is 94%, which is pretty good, right? You got up to 100, so he's not that far off. And RA is room air. Yes, he does have high blood pressure, and he's been taking his lisinopril too. So that is of good note, Emma. His blood pressure is high. Temperature is 97.9, so that's normal, right? Nothing to really fear for there. So in medicine, ER docs get to this point after you go and see your patient, you come up with differentials. Differentials translated to normal speak is what is going on. So this is the face you have when you're in the room. You just are like, what is going on? So every ER doc, right when they walk out of the room, has to have a list of differentials they can just rattle off. So feel free if you want to rattle them off in the chat, and then I'll show you the 4 I had when I walked out of the room. I'm going to give you all 15 seconds this time. You just type whatever you think is going on. There's no wrong answer, right? It can be anything. It's the ER. Who knows what Pop Pop was doing or what happened? All right. So let's go forward and see the 4 things I thought of. Nope, not related to his medication, but it was interesting. So differential number 1, the big fancy word for heart attack is myocardial infarction. Somebody put ears. I didn't think so. His hearing aids worked because they were very loud. His daughter just took them out. Stroke is a potential, but there should be more headache, head pain, not chest pain. So heart attack is number 1, or myocardial infarction as we call it. Pulmonary embolism was my number 2 differential. Pulmonary embolism is a fancy way of saying blood clot to the lungs. Pneumonia is an infection of the lungs, right? If you're old, pneumonia is always possible. It's always a good differential. It can just be there for no reason. And a lot of people asked us earlier, I put rib fractures. Rib fractures hurt. They make your chest feel worse. They can make your blood pressure high because it hurt. And who knows if he remembers if he fell in or not. Why pneumonia PE if lung exam normal? Great question. So 1, your exam is good, but it's not always perfect, right? So what if I just didn't listen to the right part of his lungs and didn't hear that crackle that makes me think of pneumonia? So that's why pneumonia stayed on my list, but as you can see, it's number 3. It's not like the top one. PE, because of the chest pain and blood pressure. Ironically, blood clots to your lungs stop the blood flow to the lungs. They don't stop the air getting into your lungs. So your lungs actually do sound normal a lot of the times with blood clots. Yes, it depends on the lobe you examine, right? So your average patient is sitting like this. So if I listen to this lobe down here, up and down, what if the pneumonia is on the back left? And I just couldn't get him to lean forward enough. Sometimes we don't take in a deep breath enough. But yes, auscultation was normal. But again, because he's an old man, I just leave on my differentials. One of the things you'll hear from ER docs is differentials aren't always the best answer, and they're not always great. They're just things you think about, right? So if someone stubbed their toe, my differential is you kicked it on the curb versus a boulder fell on it. It's unlikely a boulder fell on it, but I still think about it. So same thing with pneumonia. It's unlikely to be pneumonia, but I still have to think about it. So with those differentials, what should we do? We order an EKG or ECG, however people like to put the initials. For those who don't know, that's the little wavy sign that people always see when associated with medicine. That looks at the electricity as it flows through your heart. There's a normal pattern and an abnormal pattern. And if electricity cannot flow, that means part of your heart is dead or infarcted, which means you're having a heart attack, and it will look abnormal. All right. We need to order some labs, right? If I think it's pneumonia, he should have a white count. You can order a lab called troponin that will look at heart stress levels, and that will be elevated in a heart attack. And maybe his electrolytes are off because, again, he's an old man. Anything's possible. And of course, you order an X-ray. It rules out pneumonia. It'll look for rib fractures. Anyone who has a heart attack, if you think it's a heart attack and it's actually their aorta. That can look big on a chest X-ray. Your aorta is your large artery that comes off the top of your heart. So you always want to get a chest X-ray in anybody who says the words chest pain. So those are the 3 things. We went to our computer and we typed in very quickly. And because Pop Pop was, a little old, they brought us the EKG right away, and it looked like this. This is Pop Pop's real life EKG. I'm looking to double check so I don't get sued. I cut off his real name. I cut off his age, no birthday. The numbers at the bottom don't mean anything. So this is a HIPAA protected EKG. And Martin is correct. This is very concerning for an MI, or what's known as a STEMI. STEMI stands for ST elevation myocardial infarction. For those who've never looked at an EKG before, you're like, what are they talking about? We are talking about these. These little humps are really high, and hopefully, is my mouse visible?
I think you kind of cut out a bit.
So these arrows are pointing towards, okay, you can see our mouse, thank you. These arrows are pointing towards the QRS complexes that are abnormal. So let's try to find a normal-ish one. This is normal-ish. You have a P wave, which is a little hump before. Q is this dip down here. R is the top point. S is the bottom of it. And then T is the hump afterwards. So the ST is the point from the S to the T. And as you can see, this is elevated. It should be down here, kind of like this one. ST, nice and flat. These STs are really high. This one is really high. That one is really high. And so is that one. So we get very concerned for a heart attack. This is probably, when it comes to the ER, top 3 most dangerous diagnosis. You do not leave this patient alone. You don't do anything else. You don't go and see anybody else unless it's another heart attack or a gunshot wound. Outside of that, right now, Pop is our most important patient. And the best thing for any ER doc, we've made our diagnosis. ST elevation myocardial infarction, or STEMI, as we like to call it. So in the hospital, these are very critical. You call a STEMI alert. So you literally notify like everybody in the hospital. So you go and tell your team, you tell your nurses, you tell your techs, everyone working, hey, we have a STEMI in room X. That way everyone knows to put everything down and focus on Pop. You also need to be courteous and update the family, because what's going to happen is people are going to come rushing in and doing things. They have to put 2 IVs in the arm. They have to shave his groin. They have to give him medication. It's a very invasive time. And the family's just sitting there looking very altered, like what is going on. So you give them the update. You show them the EKG and you say, hey, these humps right here make me think Pop's having a heart attack. Once they're aware and they give you the okay to fix him and get him to the cardiac cath lab, you then call the cardiologist. What's important, especially at this age, is you don't want to do anything that goes against the family's wishes. And you'll be surprised. Some people, you'll tell them, hey, you're having a heart attack. And their answer is, if that's how God wants me to go. And you say, oh, okay, we will make you comfortable and we will do whatever else we can. But you don't mobilize all your resources until you get that okay. So the daughter gave me the okay. I called the cardiologist. I said, hey, we have a STEMI alert. I circled back and reviewed all my orders for STEMIs. And then I made sure that we got the patient to the cath lab ASAP. We look at each other, guys, give each other high fives. We're really happy. We make sure that Pop has some pain medication because heart attacks hurt. You give them some blood thinners because people who are having heart attacks are usually caused by blockages or high plaque. So you want to keep the blood a little thin. You also make sure that you get extra oxygen because parts of your heart are not getting enough oxygen. So you want to maximize as much as you can within the body. And then you just do several other orders. But at this point, we're feeling really good. We've taken care of Pop. The cath lab has showed up. And actually, these cases, when it comes to ER time, you're supposed to get them on the table for their procedure that fixes them in 90 minutes. And on this day, we got Pop up to the lab in 45 minutes. So we did really good, guys. Excellent job. So as happens in the ER, you're not allowed to move. Your next patient comes in, even though you just saved someone's life that was having a heart attack, another person is right there to be seen. So this patient's name is Drizzy. Drizzy's a 34-year-old male who's coming in with chest pain. If you do not know, chest pain is one of the top 2 diagnoses or chief complaints that you will see in the ER. Chest pain and abdominal pain are 1 and 2. Drizzy says he was watching TV and he started to have some pain in the center of his chest. He states it started to increase and then radiate to his left arm. The pain increased from a 3 to a 6, so he came in to get evaluation because he heard this could be bad. So what questions would you guys like to ask Drizzy? Any questions for Drizzy for our review of systems? His grandpa had a heart attack once. He doesn't take any medications on purpose. His lifestyle is he lives a good life. You know, he drinks on the weekend with his friends. He smokes marijuana just as he needs to. And he doesn't have any known history of heartburn, not that he's done it on purpose. He does not know his cholesterol levels. He hasn't been to the doctor in 10 years. And his chest pain started about 45 minutes before he got there. He was just watching TV. It was a 3. It wasn't bad. Then it popped up to a 6. It started going to his left arm. And he said, "No, I got to go to the ER." Any other questions for Drizzy? All right. Blood pressure. He doesn't believe he has high blood pressure, and we will have our nurse get vitals in a second. He has no known allergies. And he says that he doesn't say the pain is sharp. He says it's like uncomfortable. He's like, "I just can't get comfortable." Description of the pain. That's how he's like a pressure, just an uncomfortable pressure. Like if I could burp, it would go away, but it just won't. Any other questions for Drizzy? All right. Eating habits. He eats normally. I mean, whatever gets given to him, he says he eats. And no injuries. And he remembers. No jujitsu, no MMA. He wasn't fighting with nobody. He doesn't do those type of things, as he puts it. All right. So we go and examine Drizzy. Middle-aged male, well-nourished, well-appearing. Is on his ear, nose, and throat, moist mucous membranes. Nothing appears out of line. Heart sounds are normal. Rate and rhythm is normal. Breath sounds are normal. His abdomen soft, non-tender. Normal extremities with no deformities. Skin exam, no rush. Normal color, dry skin. His vital signs are 130/79. Heart rate of 88. Respiratory rate 16. He's satting 97% on room air. Temperature is 98.9 degrees Fahrenheit. So once again, differentials or what's going on? His temperature is a little high. 98.9 isn't crazy. For the ER and for medicine, 100.4 is fever. So that patient that comes in is like, "I have a fever, my temperature is 99. I just go, "Man, 100.4 is fever." All right, acid reflux, GERD, great. Anything else? Am I? Always. Someone says chest pain, you say, "Am I?" Always. Could it be a minor stroke? Again, no headache, so I wouldn't think stroke at this time, but anything's possible. His blood pressure was not low, it's normal. The standard perfect blood pressure is what, 120/80 is what's always in the textbooks. So I wouldn't worry about Drizzy's at all. So one thing about emergency medicine is one of the good and the bad things, it can get cookbook-like, right? Someone says chest pain, you always do the same things, right? You always think about, is this a heart attack? PE could also be possible. Maybe Drizzy doesn't get off his couch. He just sits there all the time. Pneumonia is always a possibility, but again, extremely low in this case. I don't think he has it, but I have to leave it as an option. There is the diagnosis known of costochondritis, which is an inflammation of the ribs. I'm sure most people have heard this by now. The itis, as everyone loves to call it, is a real thing in medicine. Anything itis is inflammation. So costochondritis is inflammation of the costovertebral angles and the ribs. Appendicitis is inflammation of the appendix. Gastritis is inflammation of the gastric sac or the stomach. So that's all a possibility in this patient. No, his blood pressure was not low. Blood pressure that I would qualify as low for a middle-aged male is anything below 90. A good athlete can have 90 over something. Causes of costochondritis, usually viral and mostly unknown. It's just whatever caused the inflammation, but most of the time it tends to be viral. Good question. All right, so with Drizzy, we do the same things, right? You don't try to reinvent the wheel when it comes to chest pain. Get your EKG, you order your labs. So in this case, we order a CBC or a complete blood count. see if there's any signs of infection. We want to order a CMP, which is a complete metabolic panel, and a lipase. Lipase will tell me how your pancreas looks. So that's one of the things I will do just in case in males like this, because again, your pancreas lives right here, just beneath your sternum. So when people come in, they go, oh, I got chest pain, part of that circle includes the top of your pancreas. So I love to just check that out as well. And then of course, order the x-ray. All right, so we were going back to update Drizzy, but it's the ER. So our third patient's coming in. What we do all the time is you put in your labs and orders for your patient, and then you go and see your next one, right? They're not going to be back for like 30 minutes to an hour. So you don't sit in your seat waiting to finish up case one before you finish another case. For Pop Pop, he was having a heart attack, so we didn't focus on anybody else. But Drizzy seems very stable, so we can let him sit there for a second. And now we're gonna go see Meemaw. Meemaw is a 78-year-old female that's coming in, and she says her chief complaint is reflux. She says she doesn't feel right. She says, I feel like I got reflux. She says that she has a history of reflux and some ulcer pain. She states that the pain has been bubbling up throughout the day. She states burping and taking medication has not helped. She's tried Pepto and some other over-the-counter things. She states and reports that it's just underneath her breastbone, like right here is where she points to, and it radiates towards her back at times. She states the pain is currently a 6 out of 10. Review of systems. We got 1 minute. What question would you guys like to ask Meemaw? Eating habits. She ate cornbread today with some ribs, but she cut up her ribs and some slaw. The sensation started about 45 minutes after dinner. She has not been diagnosed with GERD, but she always takes medications like Pepto just in case whenever her stomach feels bad. So she thinks she might have it. No known family history. She's felt similar pain in this location before, but she said this is way worse. And usually it goes away with Pepto, and this has not. No recent previous illness. She has reflux-like symptoms maybe once every couple of months. Nothing that she can keep track of or point to. Great questions. Anything else y'all would like to ask Meemaw? She's never been diagnosed with ulcers, but she just thinks she has one. There's been no change in her stool colors. The only thing that makes it worse is when she presses on her stomach. Meemaw says she's too old to drink, but she used to like martinis. And she's never gotten her ulcer pain checked. She just takes a Pepto and it usually goes away, so she's never really worried about it. And someone put any emesis. Emesis is vomiting. If no one knows what that is, she has not had any vomiting. She has no known pancreatic issues. So basically, she says ulcer gastritis. So we will examine her a lot to see if she has stomach pain by pressing on it. But I like where your thoughts are going. All right. So we're moving forward. She says no trouble breathing at this time. So let's go and examine Meemaw. And yes, hello to all the beautiful people. So we go in and see Meemaw. She is an elderly appearing female. She looks well nourished, well appearing. She's not in any extreme distress we can see. Again, moist mucous membranes. She has a normal heart rate and rhythm, normal heart sounds. Her breath sounds are normal. We do go and touch her stomach, and it's soft and it's tender in the epigastric, which again is that top middle area, and periumbilical, which just means around the umbilicus or belly button, as we like to call it, in those two areas. Her skin is normal without deformities. Sorry, her extremities are normal without deformities. Her skin's a little dry, but slightly pale. She definitely looks like she's lost a little bit of color. These are the vital signs given to us by our nurse. Blood pressure of 189/129. That I would definitely call high. Heart rate of 95. Respiratory rate of 16. O2 saturation or oxygen saturation is 95% on room air, and her temperature is 98 degrees Fahrenheit. So differentials, or what is going on? Any thoughts? I'm gonna take a sip of my drink. Heartburn, always a possibility. Stomach ulcers, possibility, very strong possibility. MI again, very good, always a possibility. Gastritis / GERD, yes, possibility. No visible signs, but she was tender. But her belly is also kind of like big. She's well nourished, not obese, but she has a little roundness to her. Something related to why her skin is pale. I agree, Victoria. I agree, but I can't tell you what it is quite yet. Blood pressure is concerning. No signs of ascites, which is fluid in the abdomen. She had no fluid wave. An abscess is a possibility, which she can have some infection. An H. pylori is the most common cause of reflux or ulcer, so that's always a possibility. Some sort of blockage somewhere. That is true. Something can be blocked. All right. Food poisoning, always a possibility, especially if she's not feeling too well. Maybe these ribs or coleslaw sat out a little bit too long, which would be devastating because ribs and coleslaw are delicious. All right, any other differentials? Y'all have some very good ones. All right, so taking everything you guys said, I like them. GERD and reflux, right? If the patient came in with a complaint, that's usually my number one. Meemaw seems to know herself. Pancreatitis, I don't know why it says blood clot in the lungs. It's clearly pulmonary edema. Pancreatitis is inflammation of the pancreas, so that can still be there. Myocardial infarction again, women present abnormally for MIs. So they'll say stomach pain, and it's really chest pain. And belly problems, right? So her stomach hurts. I use that as a whole category. It can be her gallbladder, her colon. She can have a UTI, a urinary tract infection, etc. Anything going on with the belly can be a possibility. All right. So to look at those things, we order some labs. Complete blood count, especially since she's pale. I want to see her hemoglobin and her hematocrit to check her blood levels, as we like to call them, see if she's anemic. Complete metabolic panel. We always call those part of our belly labs because I want to make sure your potassium, your sodium, your chloride, all of your liver enzymes are all balanced. Your lipase, again, to look at your pancreas. Elderly woman with abdominal pain, you have to rule out urinary tract infection. So we got a UA or urinalysis. Coags are what are known for your coagulation factors. That is a long tree you'll memorize in medical school. It's funny yet boring at the same time, but it's on your labs will be your PT, your prothrombin time, your PTT, and your INR. So that'll just basically tell me how thin your blood is and if it can coagulate appropriately. Yes, the 12 coagulation factors. We want to order her some medication, right? She has reflux, so I can give her what we call a GI cocktail. That is basically lidocaine mixed with Maalox to help your stomach. And then again, I would order another EKG, right? I want to make sure her heart looks okay. Yes, Christmas factor 8 and 9 are the most common because those cause the most common genetically disposed blood or coagulopathic disorders. And Christmas disease is just a great name for a disease. All right, so obviously we put in our labs and stuff for Meemaw, but this is the ER, right? Things go back and forth. So as we put in those orders, we're notified that results for Drizzy or case 2 is back. So let's look at his results. This was his EKG. Now, let's keep it simple, right? Remember the last EKG and remember this one. When people say they're the same or different, you can throw in the chat, same or different. Different, exactly, different. So if the first one was bad and we stopped doing what we were doing, And this one's different. It's okay. This one is completely normal. I'm gonna go back and show everyone the complexes we were talking about earlier. So up here, if you can see my mouse, right above it, this little hump is your P wave. This little dip right here is your Q, R, S, and then this is the segment before your T wave. So that's why this is the ST. So last time this was really high, and that's how we knew it was a heart attack. But otherwise, normal. All right. This is difference between the V's. Oh, are you talking about these V's? 1, 2, 3, 4, 5, 6? Great question. So when you put the leads on someone, I'm trying to position myself so you can see my chest. You place 6 leads right here across your precordial area. 1, 2, 3, 4, 5, 6. So it measures the electricity in different places. That's why it looks kind of different. So as electricity is flowing from here across through my heart, you can see the amplitude gets bigger throughout and then flattens out again. So they're like mirror images of each other. So they're just lead placement. These V's look fine. But great question. And then AVR and AVL are like other places on the triangle up here and down. When we put our stickers on the lead, it prints out like this. So this is a chest x-ray. I'm not going to force you guys to look at it and know what it is. But when you get a chest x-ray, I'm going to give you guys some simple tips. One of the things we like in emergency medicines are ABCs, like everything has its own ABC. So for a chest x-ray, your A is your airway, which is your trachea, this darkness. Darkness is air, so you want air to be in your trachea, in your windpipe. You follow it, it should split into 2 areas, and that should be great. You should see darkness all the way to the edge. That's good. And then you can look at your bones here. We're not going to spend too much time, and make sure there's no fractures, right? It should be a straight line all the way across, all the way across, all the way across. Your diaphragm is down here. It's this flat portion over there and flat portion over there. And beneath it is your stomach on this side and your liver on that side. And this giant thing in the middle is your heart. So looking at Drizzy's, I can tell you guys his chest x-ray looks extremely normal. I would not be worried about it whatsoever. No pneumonia, no rib fractures. His heart's normal size, normal airway, looks great. Oh, look, case 3. We're not done with Drizzy yet. You have to switch your mind back to your other patient because emergency medicine, you keep moving. Meemaw's labs are back. This is Meemaw's EKG. Normal or not normal? We just did this. What do you guys think? Exactly. Normal, right? In fact, it almost looks like someone just copy and pasted Drizzy's, right? Like who would do that? But you are correct. It is a normal EKG. Nothing to worry about there. So heart is probably out of the picture for Meemaw. Oh, wow. It's case 3, right? Look at this chest x-ray. It looks really normal. Like we almost just saw it. The airway is great. It's patent on both sides into each lobe of the lung. The bones going across. I don't see any fractures. Also, when people say they count their ribs, this is how you count them. 1, 2, 3, 4, 5. That's how we count them on x-rays. That's how we can tell you which rib you fractured. This x-ray looks normal. I love it. It's almost, again, copy and pasted like it's normal. It's great. Let's move on. So now we're back to Drizzy again. We're on case 2. All right. His labs came in. CBC, or complete blood count, normal. The CMP we ordered, normal. Troponin, his heart test, normal. Lipase we ordered, normal. All right. Whenever you get your labs and your imaging back, if you can't get in, always send in your nurse just to double check. She could repeat some vital signs, 133/80, heart rate's 85, respiratory rate 16, O2 sat's 99% on room air. I mean, that's great. Temperature is 98 degrees Fahrenheit. And when we asked what the update was, she said he's resting comfortably. All right, good job. So we start thinking about what we want to do with Drizzy, but Meemaw's labs are also back now. On her complete blood count, her white blood cell count was elevated. So your white blood cells are your infection fighting cells, is what people normally call them, but I like to think of them as your stress cells, all right? You're not always fighting an infection when your white count's up. You can be really stressed. You can be running a mile. Someone could have shot you, and since your body is trying to heal that area, it can increase its white blood cell count. So it's usually bad. You can definitely think of white blood cell count as bad, but it's not always infection. So right now we know something bad's going on with Meemaw. We look at her comprehensive metabolic panel, and her liver enzymes are a little up. We don't like that, but that also tells us something's going on in the stomach. Her troponin is normal, so it's not her heart again. Her lipase is normal, it's not her pancreas. We're okay with that. Her vital signs look like they're getting a little worse, right? Her blood pressure is now 198 over 130. Her heart rate's now tachycardic. It's above 100. It's 115. When she came in before, it was normal. I think it was about 89 or 90. Now we're in the 100s. Her respiratory rate's now 20. She's breathing faster. And her O2 stats are dropping. She's now 92% on room air, but still no fever, 98%. The nurse tells us, yeah, Meemaw said the pain in her stomach is getting worse. She looks a little pale. Now the nurse notices it, and she looks short of breath. So we have Drizzy and we have Meemaw. Which patient would you guys like to go see first? Which case should we conclude first as ER doctors? Yeah, definitely, right? Meemaw, case 3. Exactly. There's no reason to rush and see Drizzy. As an emergency medicine physician, you have to prioritize all the time your patients for level of acuity. Right now, after we sent off Pop to get his heart attack fixed, she's definitely the sickest person in the ER right now. So off to see Meemaw. We re-examine her, and now she's pale. That should be female, I forgot the FE, but she's pale with worsening vital signs. Her abdomen's now more tender and more distended. So it hurts more when I press on it, and by distended, it's poking out more than it was before. Remember I said she was a little rotund before. Now it's like visibly obvious that she has a little pouch there in her stomach. And the families with the bedside is really concerned about Meemaw. They're saying she's not looking right. We don't like the way she looks. Someone asked the question, hepatomegaly, that means enlarged liver. No, it wasn't just in the right upper quadrant. It seemed to be the whole abdomen and still no fluid wave. And an infection is still a possibility, but no x-ray vision on me. But I do have an x-ray department. So we order a CT scan of her abdomen with contrast immediately. We need to see what's going on in that department, abdomen, excuse me. Also, when you order a CT scan, your patient leaves the department. They're out of your care. So you got to be very worried when you send off sick people to CT. There's a joke in EM that radiology is where people go to die. So you don't send them there unless you stabilize them. So we make sure to tell our nurse. We send our nurse down with her. We make sure they have a crash cart prepared in case anything bad happens. And we want this CT scan immediately. We want to look at the liver. We want to look for infections. We want to do everything. But now she leaves the department. So as an ER doc, when someone leaves the department, they're still critical, but you're not managing them acutely. So now you need to go handle all the small stuff while you can. And by small stuff, I mean Drizzy. So we go back to Drizzy. We need a diagnosis. Does anyone have a diagnosis for Drizzy? I like what I'm seeing. That's what I thought too. I don't know. I don't know what Drizzy has. I don't know at all. He could have anything. He seems fine. He's not dying. So when you don't know, sometimes in emergency medicine, you just shrug your shoulder. It is a fallacy that every time an ER doc sees a patient, they have a diagnosis for that patient. It's never true. We have a diagnosis for the vast majority, or some people you just don't know. So there's literally a diagnosis, ICD-10, that you can charge for. That's called chest pain of uncertain cause. That's what Drizzy has. He has chest pain of uncertain cause. So we have no clue what he has. So we can measure his risk factors, right? So there is something in the cardiology and EM world known as the heart score. You assign 1 point based on the risk factors. 0 to 3 is low risk. 4 to 6 is medium, and 6 and higher is high risk. So he's a 3. He's low risk. We think he can follow up with his doctor. And that's probably the second most or the most important thing we do as ER docs. Can you go home or do you need to come into the hospital? And we've determined that Drizzy can go home. So disposition, discharge to home, follow up with his PCP or a cardiologist. You give him paperwork. His pain is improved, right? The nurse said he's resting comfortably, so he doesn't need pain medication to go home. He can take some Tylenol and Motrin, follow up, bye-bye. Drizzy's gone. So Meemaw came back from CT. Do you ever get nervous sending people home from the ER, no diagnosis? All the time. But you have to assess your risks. So I like to think of it like this. If I'm going to go home and go, can I go home and go to sleep, or will I go home and think about the patient? If I will be thinking about the patient, they need to be in the hospital. So you can also admit somebody for chest pain of unknown origin. And you say their risk factors are high, cardiology needs to see them in 24 hours. You bring them into the hospital for what we call a chest pain rule out. But Drizzy's a 30-something-year-old male that was watching TV. The pain's completely gone. Risk factors are low. I will never think about him again, except that his name is the same nickname as Drake. Outside of that, he'll be okay. But Meemaw, I'm not going to sleep until we figure out what's wrong with Meemaw. So she returns from CT. She looks sicker. And the CT tech tells us, I don't like the picture. So great question. When you're an ER physician, it is you. You can curbside or consult other people like, hey, I have this patient, what do you think? And get their opinion. But at the end of the day, legally, it is on you. So for people who are moderate or middle risk, you can always call a cardiologist and say, hey, this guy Drizzy's here. Here's how he came in. What do you think? And they'll give you their opinions on the case. But it's always up to you to make that final decision. It's tough, but you get a lot of practice. Trust me. So the CT tech says we don't like the picture. Does the radiologist provide a report? So great question. The radiologist called us and said, hey, I'm sending you the picture. I think you should look at it right away. I'm gonna finish my report in just a minute. So we go, and this is our picture that we got. This is one slice. So when you get a CT scan, it's hundreds of slices of the abdomen. So this is literally one picture of it. And a lot of people are looking like, what the heck am I looking at? But I know everybody on here without a medical degree doesn't know what they're looking at, but they probably know that's bad, right? That just doesn't look right. So this is where your aorta should be on top of your spine. This is really big for an aorta. When you give someone contrast, it should fill up the whole aorta because that blood should be going through the entire tube. There is contrast here. There is none out here. That means that the aorta has two different paths or lumens in it. That's not good. That means it has a balloon in it known as an aneurysm. So she has an abdominal aortic aneurysm. Danger. Extremely scary. The aorta is the biggest artery in your body. It carries blood from your heart through your chest, down through your abdomen, and then all the branches of your arteries come off of this aorta one way or another. So if it's not acting properly, danger. So an abdominal aortic aneurysm, you get very concerned that it can rupture. If it ruptures, you're bleeding out. So rupture means hole. It can be a small hole and trickle out slowly. It can be a big hole, boom, all the blood rushes out immediately. So as you can imagine, there's a very poor outcome with rupture, but you can fix it. And I wanted to point out one thing, as you're studying for the MCAT and going through everything, you're like, why does physics matter? It doesn't really matter, except in cases like this, right? So I have a tube that is ballooning and getting bigger than it should be, and I don't want it to pop. So I have to figure out what would make this tube pop. So there's an equation for shear force, right? I know, right? Everyone's like, he did not bring up physics. So in shear force, you have force over the overall diameter of the tube that you're in, right? So if you did even 3 minutes of physics, we all know force equals mass times acceleration, right? So acceleration is how fast the blood is going through that, right? So that's your heart rate. Your mass is how much blood is going through that. That's your blood pressure. So every ER doc needs to know that if I don't want this tube to shear or pop open, I need to decrease the force on it. So I need to decrease the acceleration. I need to decrease the mass, how much blood is getting down there. So our next steps are pretty easy from the ER standpoint. Pain medication to relax the patient so they're not stressing down, right? When you're hurting, you're, and every time you press on your stomach, you're making that aorta bigger. And then you give a medication called a beta blocker because it will lower the blood pressure and the heart rate at the same time. Extremely important, right? Especially when you look at that equation. All right. Is F equals mass times acceleration essentially a variation of cardiac output, which is blood pressure times stroke volume? Yep. I didn't make the equations. I would say essentially a variation. I'm sure there's some physicist who says it's like this number that's different, but that's exactly how I think about it, basically. So next thing, remember, when you have a terminal emergent diagnosis, you inform the patient, inform the family immediately. So we tell them that this tube is in the stomach, we need to lower it, we need to get what we can done. We notify our staff, hey, Nurse X, Meemaw has a AAA, we need to get that low pressure going immediately. So they know to go and get it, right? We've now informed them of a terminal diagnosis. This is not, oh, Dr. Nyes put in the order, I'll start it 5 minutes later. Every second matters. Every time that heart beats, it is putting extra pressure on that thing to pop. And then as ER docs, we have to determine, can we admit this patient here at this hospital, or do we need to transfer them to another hospital? And on this day, when you guys are shadowing me, there was no vascular surgeon or a surgeon that does vascular and works on vessels in our hospital. So we're gonna now have to transfer Meemaw. So now we're making phone calls to other hospitals to figure out who has a vascular surgeon in the closest area to us. So as we're doing all of this, we have to remember that it's not over until it's over. So Meemaw is not healthy and stable until she is gone, all right? She is still in our care. She's not like Pop Pop, who got to go to the cath lab just upstairs and was gone in 45 minutes. She could potentially be in our care for hours. So we have to do multiple reassessments, keep her blood pressure low, keep her heart rate low. So because we know that, we put in our orders, we call a transfer center, we got her transferred somewhere, we go back and re-examine her. We reevaluate her again, and now we know that she has a AAA. And she starts vomiting. Vomiting is not good. Everyone puts their hand on their stomach right now and pretends to throw up. Doesn't it feel tight? Don't you feel that increased pressure? That's where that giant tube of blood that we don't want to pop is. So every time she vomits, that is a very bad sign. We examine her. Now she has a different heart rate. It's still kind of elevated, and her rhythm is abnormal. It's not consistent. When we look at the monitor, it's a little bit of AFib, just means an irregular rhythm. And she has a change in color. I mean, she was kind of pale before. She matches the sheets at this point. And she is visibly short of breath. Like she's having difficulty breathing and she's vomiting at the same time. Not good at all. So we still need to focus on what the life-threatening thing is. So I tell the nurse, instead of dripping in the medication slowly to lower her blood pressure, hit her with a slug of it. Someone said, what's the reason she's vomiting? When your body starts to lose blood, it can get sick and make you very nauseous, especially, and with the pain in your stomach, that combination increases your nausea. So she's vomiting for that. You would think the body would not want to vomit, but it doesn't know exactly what's going on. It just feels space in the stomach expanding and less blood flow is getting to the gastric organs. So your motility has gone down. So now you're just vomiting. Does vomiting compensate for anything? It does empty the stomach. So now there's not like food in there. So your body will stop shunting blood to that area, but it doesn't make it better. At least your body doesn't know that. Also, Meemaw was in a regular room, and now we moved her to a trauma room, right? A big room where a whole bunch of people can come in and surround the bed and take care of her all at once. So we got Meemaw into a trauma room, and we have to not only lower her blood pressure, we have to talk about stopping the vomiting and stopping her decompensation. We need to take over for her body. We need to put her body to sleep. So we obtain consent for intubation. That's where you place a breathing tube in the throat. We put her on a ventilator. So now her body doesn't have to worry about breathing. We can give her some paralytics. We can take over for her brain. Her body doesn't have to think. We're going to handle everything now. So they give us the okay, and the nurse brings out our intubation tray. Is there a reason? Is this the same as medically? Yes. So medically induced coma is what I like to call the news way of talking about it. Because you put them all the way to sleep, it's kind of like a coma, but if you don't do it deep enough, they can still hear and understand things. But basically, yes, we're putting her in a medically induced coma and placing a breathing tube in. These are just variation of tube sizes right here, from a pediatric baby size all the way up to an adult size. These are the different blades that we attach to this knob right here. These are more blades that we can use. You attach it to the knob, you pop it open, there's a light. The patient lies down. You put the blade in her mouth, because I'm at the top of her head, and I lift it up so I can see her vocal cords and I can see her breathing tube. I take one of these tubes with this balloon not inflated. I put it through her vocal cords. Then I blow up the balloon so it can't be pulled out. Then you attach this portion right here to a ventilator or a bag. And now we can breathe for her. And it's very important, as was put by Caroline, to put her in an induced coma or give her a bunch of medications to put her body to sleep so it doesn't try to breathe over our machine. This is not what Meemaw looks like. This is just a picture of someone off the internet who's intubated, but this is that breathing tube that we had. This blue and white are tubes from the ventilator that connect to that breathing tube. This portion right here is just suction that you can put through the tube to go in the lungs to suck out mucus or anything else along those lines. And this yellow tube here is an NG tube that you can put in to drain the stomach so they can no longer vomit. And then these are just medications hooked up to her IV port, which you can see is accessed right there. So we now have managed her ventilator. We're breathing for her. Her blood pressure's gotten better, gotten a lot lower, and the flight has arrived. The patient is now being loaded up on a helicopter to be flown to a different hospital. Meemaw is doing okay. And if anyone's wondering, like the real Meemaw is actually doing okay. So we can exhale. We have saved a life. They're gone. You can drink your Coke or Diet Coke or Sprite in my case, and get ready for your next case. We're not going to have more cases. We're going to have 3 cases today. Thank you. I wish I was a superhero, but just a doctor. I am putting on my Tour for Diversity swag or fleece at this point, because now I'm going to get to promote to the company a little bit. Tour for Diversity is great. The mission is to diversify medicine, and people kind of always ask me, like, why do you think you need to do it? And when I tell people I work for this organization, one of the number one thoughts is there racism in medicine? Don't you just treat everybody? I will tell you, as a doctor, handling racism on shift has been very rare because, right, people need me to save their life. They're not really willing to curse me out, but it has happened. I've been called racial slurs and all kinds of things, but those people are usually obviously not dying if that's the way they want to act. And sometimes they are, and they just can't get over their bigotedness. But racism is everywhere in the world. So it is my belief, and some of the beliefs of the organization, that if you can diversify medicine and change people's thoughts on what a doctor can look like and can be, you can improve the world one doctor at a time. And if you think about it, it was medically acceptable at one point to treat people of different colors differently. Like literally, there were textbooks about it. So if you don't have the right people in there and medicine's not diverse, we can get the wrong ideas and they can be propagated the wrong way. So my thoughts on diversity are multifold. There have been studies, multiple studies, that show people feel better when they trust their physician. And one of the things they trust most about their physician is that they believe that they understand where they've come from. And the easiest way is just to look and say, this person looks like me, this person cares like me. Unfortunately, like I mentioned before, we've had some devastating things in this country that have made people uneasy. I've seen a lot of African-American Meemaws that can't trust white doctors all the way because of what happened with Tuskegee and other things. They still go to them and they still believe them. But what I mean all the way trust is that blind trust to just do anything they say. They still think about it, or will look up internet memes and see if a horse dewormer will be better to solve their viruses or something like that. Again, because they just have this trust that's lacking. And that's fair. So the hopes that, again, is if you kind of diversify medicine, when people come in, they feel like ease. I've definitely walked in the room sometime and someone who was feeling bad smiled or gave me a thumbs up, or I'm not related to them at all and just said, I'm proud of you. And it's like, oh, great. I'm glad I can be that person for you. And last but not least, not on the major diversity tip, but for anyone in this listening to me, mentorship is necessary to get to medicine. Everyone has it. Everyone's talked to a doctor, seen a doctor, or will need one at some point. No one can get I'm going to say no one, because I'm sure someone's done it, but it's very rare to get a perfect MCAT score, get perfect med school grades, and fly through residency. You're going to need somebody along the way. So you guys are taking great steps to do shadowing like this. I would implore you to look for different mentors in different areas who can just keep up with you, read your personal statements, send you to good med schools, bad med schools. And sometimes it's just not what you know, it's who you know. That's been proven a million times in this world over and over again. Great point, super necessary. Sometimes your mentor is the only one when you're crying over that physics, trying to remember the shear force examination or equation, that mentor can tell you why it's important or why you need it. But I promised I would leave at least 25 or 30 minutes for questions. So again, drop the questions. I don't know, AM, if you want them to unmute or not, but I'm here to answer whatever.
Yeah, sure. If you guys feel comfortable, you can go ahead and unmute or put your questions in the chat. Either way, just please maintain respectful.
I do have a question, and sorry for the background noise. I just have my brother here. So, I don't know, like, how do you feel being part of emergency medicine, knowing like you're not going to see your patient again? Like, you send them off and you don't know what they have.
So, to be honest, most ER docs will tell you the truth, which is we feel good about it, because the dangerous ones, the sick ones, we do know what they have, right? I knew what Meemaw had. I knew what Pop have. Again, I'm not going to lose sleep over Drizzy. He'll be okay. And some primary care docs don't know what their patients have. So I don't feel any worse for it. Also, little known fact, or probably big known fact in the US, people come back to the ER all the time. I joke that at our ER, we have platinum members. I mean, this person comes into the ER at least 8 to 10 times a month, right? Like minimum. I see them all the time. They have the same complaints, and I know that I'm going to discharge them to come back. So some people you do see over and over again, and some people you see for different things and grow up. So it's not as close as a continuity as a primary care doc, but it's pretty good. Have you ever misdiagnosed a patient? If so, how'd you deal with it? Oh, yeah. I mean, you get things wrong all the time. Again, the big ones you shouldn't miss, and that's why we're tested on the big ones. But the small ones, like the GERD, and it came back and it actually was a heart attack, has happened to some people. I have seen someone with back pain and got like x-rays and it was negative, but then got like a CAT scan and MRI and it's like a teeny tiny fracture. So I don't feel bad because I made the best diagnosis I have with the resources and tools I have. And sometimes some things just don't present until you get to the next step. And I tell people that all the time. Textbooks are very, very thick. In emergency medicine, I can only know certain portions of it. So I will need to send you to a specialist. So it happens. I just don't think I missed any of the big ones. Next question is, I'm also interested in radiology. Out of curiosity and your experience, does the radiologist tend to stay on the case and help with the diagnosis, or they just take pictures, write a report, and then they're off the case? So radiologists will always tell you that the cool ones that they like, they'll keep like a folder of those pictures. They love staying with it. And sometimes if they're really interested, they'll call back. But every cool picture, they'll always call you and ask for the story. So like in Meemaw's case, they were like, hey, Dr. Anani, this is so-and-so. Are you taking care of Meemaw? Like, yeah. Well, what's going on there? Well, she's here with some abdominal pain. She's sweaty. She looks kind of pale. Her abdomen hurts. Well, I don't know if she knew this, but she has a AAA. And then they'll follow along from that. If you order no more imaging, they'll know you probably dispo them. And every now and then they'll call back, but they care about the pictures mostly. Well, let's see. I know a lot of times people who are homeless will go to the emergency department, especially during the winter times, mainly just for shelter because they cannot be turned away. How are they treated, and do you interact with them at all? So first and foremost, everyone who comes to the ER, unless they say, I'm just here to get out of the winter, treat as a real patient. You will get burned being like, oh, so-and-so is homeless, don't believe their chest pain, and then they have a heart attack. Do not do it. People may not run to their room as fast, but again, do the same thing over and over again to not get caught up. So they're usually treated relatively well until they start getting grouchy, like demanding sandwiches and things like that. It's like, you have to wait, you have to wait. The hardest part though, for me, is when it's time for them to go home, because you know they have no home to go to, right? Like, let's take the Drizzy case. Your average chest pain workup takes 3 hours. So at 3 hours, 3.5 hours, I'm supposed to walk into this homeless guy's room and say, go back on the street. So sometimes you have to. You can offer other resources. If it's late at night and snowing, you'll say, all right, you can stay here till the morning. You put them in the room and just say, hey, you're not going to get a nurse. You're discharged. But if it's noon and sunny outside, you should just let them go now so they can find shelter and not get locked up. Jackie says, I was a medical scribe in the ER for a short period of time. The fast-paced environment was so overwhelming for me, but I realized that's the environment I want to work in. Any encouraging advice? The best encouraging advice is to keep going back over and over again. ER is one of the great places where shadowing actually does work pretty easily, because you just follow somebody around. And then when you just realize that you can only take care of one person at a time, you'll learn how to juggle those balls pretty easily. But you're not going to get it right now as a scribe or an undergraduate. It's going to take practice. When I was in med school, I can only carries how many patients you have personally, like 3 patients at a time. Now I can carry 18 patients at a time easily. So we're just talking about practice. What were your extracurriculars to get into medical school? I was a band nerd, clarinet, second chair, all the way through. My high school didn't have sports, so I did band into college. When I was in college, I was part of a lot of associations. Black Student Alliance, African Student Association, Pre-Medical Association, Men of Color, Student Government. Yeah. And then I tell people it's great to be in organizations. It's better to be leaders of them. And it just looks better. So, anyone can list that they went to the sign-up fair and signed their name on some organization list. But when you become president, treasurer, secretary, and you can do it for a year or two, it shows that you're committed. Probably cliche question in these times where we are having increased discussions about burnout. Burnout's real, guys. Burnout's when doctors just get tired of doing medicine and get grouchy and angry. What does work-life balance look like for an ER doc? So, secret, ER docs work less than your average doctor. So I am contracted at my site for 12 to 13 shifts a month. So 30 to 31 days in a month, I only have to go to work 13 times, right? So I can work 3 shifts a week. I can work 5 shifts one week, take the next week off, work 5 shifts the next week. So you get to schedule your schedule how you like. The only bad thing about that balance for ER docs is you have to work on the holidays, right? The ER doesn't close on Memorial Day. So I worked on Memorial Day. People brought me barbecue, but I did not go out and eat any or go on any boats. But you have to do that. So the work-life balance for me is all about a schedule. You share your schedule with your family. They know things early. Also with ER, your schedule tends to be made 60 to 90 days in advance. So like right now, I know what I'm working through July, and we're already working on the August schedule. So you tend to plan things like this, right? Like I have the evening off. I knew I can come on and do a talk. I work tomorrow night. I have the next night off. It is what it is, and you get used to it. And during your free time, you have as much fun as possible. Are clinical volunteers mandatory applying for medical school? No. They're encouraged, they're liked, but they're not mandatory. You can do non-clinical as well. They want to know that you're interested in something and that you stuck with it. They want to know that you care about people. So, if your non-clinical volunteering is like sewing sweaters, it's like, okay, it's not really very medical. But if you're sewing sweaters for the homeless because you cared about them, okay. So you just relate it back to patients all in the end. How can we be part of Tour for Diversity Medicine? Great question. Follow us at these places. As a student, you can't be part yet. We do let med students join, but we want to get you guys into med school first. We're not going to pull you into doing IG lives or things like that. So follow us on these places, keep up with this. I have many a mentee who started off as a med student that's now a physician and that can now join us on the tour fully. So we would love the same things for pre-meds. And I have a pre-med mentee who got into med school. I did an IG live with them. It's on our Instagram page. It's very interesting to see that. I met her at Hampton and now she's a doctor. So we love these stories. We love to promote them. Her name is Louisa, Dr. Apia. You can look it up. But you can't be part yet. Get into med school and we'll talk again. Does your job require any academic work, such as attending conferences and research to learn about new medicine? So interesting question. In medicine, you can be academic or you can be private practice. So my wife works at Vanderbilt, that's academic. For her to get promoted, she has to do papers and go to conferences and things like that. For me, I'm private practice. Work, 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 work. I do go to conferences because I like them and meet other people. And for every specialty, you have to have something called CME or continuing medical education to stay up to date. You need a certain number, it varies for specialty. But yes, you have to go to conferences for those things. But it's not mandatory. You can just read books sometimes. As an ER doctor, do you ever experience anxiety? How do you deal with anxiety? I wouldn't say anxiety versus like a rush. So I always know in ER at the bare minimum, kind of similar to Meemaw, if I can stop your body from working hard, I can have time to figure it out. So if I have to intubate you, put you in medical coma and do whatever, that's what I have to do to figure it out, then that's my end game. But I try not to get anxious because that makes the patients feel worse. And if I do need to get anxious, I go into like a room and like exhale and do it there. But staying cool as a cucumber in front of the patients and nurses usually makes your job easier. Will this doctor shadowing meeting be held periodically or sometime in the future? Well, shadowing organization, Pre-Health, does it all the time with various people. If you want to shadow with Tour for Diversity mentors, we normally have to be contacted on a private basis, but we usually meet students like this more frequently in the virtual base. So again, if you follow us at those places down low, you will hear all of our opportunities to come and shadow or follow us. Do you take volunteers at Tour for Diversity? Not unless you're in medical school. We, again, want people to get there first. One of your favorite books that you recommend, medical or non-medical? My favorite book in the world that's non-medical is Ender's Game. It's great. They made a movie about it. The movie wasn't as in-depth as it should have been, but man, just looking at how someone interacts with their family, how you can push them to the brink, it's great. You can contact me on IG if you like. I will put it in the chat. You can also go to the T4D underscore, I think it's Anani. That looks right. You know what? Just go to Tour for Diversity, at Tour for Diversity. I'm in like half their publications. Then you can just figure out my @ from there. I don't want to type it in here wrong and then mess you guys up. Or I can just look it up right now. Thank you so much. Oh, thank you guys. I'm really glad y'all stuck with me. I was worried this would either be too boring or too intense. Yeah. So the IG is T4D underscore Dr. Anani. And the Tour for Diversity one is just Tour for Diversity. High school shadows at my hospital can happen. Someone wanted to know, and I'll share it with everybody, but you get to live in Tennessee. So if you get here, you go to the hospital and you apply, and they'll contact me if you made it through their places. I just recommend anyone go to your local ER. Most of them will allow shadowing people. It's pretty easy. Oh, thank you guys. I'm glad you felt like you were in the ER room. Shadowing is supposed to feel like you're doing it. So that's what I was trying to pass on to you guys. I will gladly come to PHS again if they'll have me. I have to come up with 3 new cases, but I guess I work 13 shifts a month, so that's very possible. And I will switch up the names, I promise, and correct some of the gender pronouns I messed up, but I will do my best. And I do believe we have other T4D mentors. They do other cool things in other specialties. So you guys should track them and see theirs as well. Oh, thank you guys. And again, PHS, you guys are excellent. I would have never put my like few brain cells together to say, hey, people can shadow virtually. Let's get that out there. But clearly it works. So you guys continue to do it, fill out that post survey, get your hours, and I hope to see you guys on the other side of this, either in medical school or when you guys become ER docs, whichever one you like. And I'm still open to questions. I was told I get to be here till 9:30. So whenever you guys are done, you can leave me or whatever you like to do. Oh, someone asked a question. Does a BSMD program take less than the traditional route? Yes, because your BS is usually contracted to 2 years, and then you do just the 4 years of med school. So it's 6 overall instead of 8. So my wife only did 6 years of school before she graduated med school, where I did 8. But I had more fun in college, so that's great. Any tips for prepping for MCAT? Practice. Learn your study style, all right? Sitting in a coffee shop and reading the book over and over again and doing questions may not be your study style. Maybe someone else's. You may need audio, you may need visual. So figure that out. And people always ask the inevitable, should I take a Kaplan course? Should I take whatever course? They're not bad, and Torreford University does not endorse any of them specifically. However, I did one, and the one thing I found that was good about it was how it helped me with time management, right? Those courses are only for like 2 or 3 months, and they'll have everything stretched out each day. So I didn't have to come up with my own calendar. I just followed theirs. When you're doing your own studying, you gotta make up your own calendar. That was something I didn't want to do. Did I take a gap year? I sure did. I knew I could not study for the MCAT and pull a decent GPA. And by decent GPA, I mean 3.001. Very proud of that GPA. Yeah. You don't need a 4.0 to go to med school. That's a lie that's been perpetuated since the beginning of time. The better your GPA, the easier it is to get into med school. So every number below 4, you're making it harder on yourself. So yes, I got in with a 3.001, but I got into one school and then waitlisted to another school, where someone who had a 3.7 is probably to get into 5 or 6 or 7 or 8 schools. So again, don't aim for my GPA, do better. I barely made it, but it's a possibility. But gap years are almost more common nowadays than going straight in. And every person on the other side of the table knows that. We just want to know what you did with your gap year. So you can only study for so long, so that can't be your answer. What did you do after studying? After I studied, I worked for my aunt's home health agency, and I went and saw patients on her side, and I helped her organize her business and worked for her. That was great. I don't know about the link for the survey for hours. It's on the website. There we go. Did you take a postbac? I didn't, because I felt like with 3.001 at the time, that was competitive enough to at least look at my application. So my goal was just knock out the MCAT and you'll be good. The balance with MCAT plus my extracurriculars, which were like pages long, as you guys heard me recite, plus that GPA, I thought was enough to get me into at least one school. And my gamble was correct. How'd you do it? Getting in with only 3 points. The balance. I had that, but my extracurriculars were super long. So to schools like Howard University College of Medicine, extracurricular, student of color really mattered. They saw my leadership, and my MCAT score was above average at the time. So 25 then was really good. So again, if you're deficient in one area, be better than the other, right? If you watch sports, Steph Curry is the best 3-point shooter of all time. His defense isn't very good, right? But he compensated by being the best 3-point shooter of all time. So if something's off, fix it with something else. And know when some things are just unfixable, right? Like 2.7, very tough to get in medical school. You need that postbac. I will tell you right now. 3.01, I made the gamble. And if I didn't get in that year, I would have done a postbac and probably made it my next year. What made me stand out to med schools? What did you do during your undergraduate years to make your application more appealing? I think it was the leadership and the longevity. So case in point, Black Student Alliance. Joined that when I was a freshman. I was a board member by my second year and third year, and then president by my fourth year. With band, right? I played all 4 years of the clarinet, and I was first chair in college, second chair in high school, first chair in college, all 4 years. Men of Color, I restarted that organization. being part of the Carleton Student Association for 2 years was really important. So I did things that when people wrote my letter of evaluation, it wasn't just like, Love is a nice student. I have worked with Love and he was great. It was, Love is a great student. Love has gone and been in leadership. When I asked Love to do this, he did that. He helped our school, did this and did that. So that's where you stand out. People sleep on the letter recommendations. Very, very, very important. If someone can talk highly of you, especially if they're a professor. Nothing wrong with your pastor writing you one. I think I had a pastor written one too. But those ones written by professors go a really long way. What would I say the minimum GPA for med school is? If you ask me, based off of my GPA, you can't get below a 3, especially when you break out the sciences. I think the 3 is as low as most schools are willing to go without a post-bac. Unfortunately, with time and inflation, and by most of your responses, I agree, a 3 is a lot tougher than it was back in, what, 07, 08 to apply. So that 3 does need to be maybe a 3.2 now or a 3.3 on the lower end. But I would say a 3 is the bare minimum. Where I see students stressing out, and I think is really weird, is when people have like a 3.5 and they think they won't get in. That's perfectly fine. 3.3, even to me, with the right application, I think is decent enough.
Awesome. Thank you so much, Dr. Anani. So we have reached the end of our shadowing session. The quiz is up, and I will be going ahead and sharing the screen for the wrap-up presentation. All right. I have issues. Okay, there we go. So let's reflect. What brought you to the session today? What are 3 major takeaways that you got from this presentation? And what do you want to learn more about? You can go ahead and put that in the chat. And once again, I have included the links all in the chat. You just have to scroll up probably a little bit, but if you want some recognition, have any articles, reflections, reviews, or anything else, you can go ahead and submit your thoughts on today's session via using the link of prehealthshadowing.com/blog submissions. We always accept them, we look over them, we have a whole team, so it's great. And if you're interested in being part of pre-health shadowing, we are always accepting student volunteers, and we're currently looking for team members. And it's great. You should join. I'm a team member. I recently joined. And if you can donate, we would highly appreciate it. Like I said earlier on, we do like solely go off of the time of our volunteers and of course the donations that we get. But yeah, it really helps us maintain our website and just in general keeping the organization free for everybody. Now that we're at the end of the session, I'm here to inform you that we do have earning a digital certificate for attending this. It's a simple 10-question multiple choice quiz, and it's based on a presentation. You have 2 chances, and you need to pass with a 70% or higher for the verification. And the quiz is open indefinitely for your convenience. And if you missed any part of the session today, you can go ahead and visit our YouTube channel to watch any of previous sessions or this one. This one will be posted soon as well on the website. But yeah, be sure to catch up on our sessions every week. It's on our website. You can go ahead and subscribe to our email list and follow us on our social media to not miss any future ones. See you guys next time. Thank you so much for joining. You could go ahead and stick around and ask any questions you have. Thank you.
Hello, I have a question or something to bring up.
Sure, hi.
Hi, so I don't know if my name's Kanissa, and